welcome back everybody to another episode of our renal content. So today we're going to talk about fluid physiology. This is going to be closely followed by the next video where we're going to talk about filtration physiology, and that's where we're going to dive more into some of the calculations and things you guys need to know. This is more about understanding, how filtration works, the physiology behind it, and things like that. So if you guys are ready, then off we go. The first thing I want you guys to pay attention to is something called the 60-40-20 rule. And basically what that means is that approximately 60% of our total body mass is water, so 40% is non-water mass. Of that 60%, about 1/3 of it is extracellular, and the other 2/3 is intracellular. Of the extracellular fluid, about 3/4 or 75% is interstitial fluid, and about 1/4 or 25% is what we consider to be our plasma. Pay attention to the certain ions that are intracellular versus extracellular here. Intracellularly, so things inside the cell, is going to be things like your potassium, our magnesium, and our phosphate, right? So those things inside the cell. And this makes sense because we know we have certain transporters, let's say like the sodium potassium pump is pumping a bunch of potassium inside the cell with a bunch of sodium leaving the cell. So inside the cell is where most of our potassium is. Extracellularly is things like our sodium, our chloride, our bicarb, and our albumin, right? Because albumin is a very big molecule that has a hard time getting into the cell. So keep those in mind. Sometimes this will have a correlation with some pathologies, like things like such as tumor lysis syndrome, where cells are essentially destroyed, they lyse, right? So if a cell breaks here, and then all that potassium can leak out, and this can cause people to have a hyperkalemic state. Next, we're going to talk about Starling forces. So these are super important. A lot of times they will expect you to be able to make these minor calculations and kind of figure out what's the net value for the Starling forces. So here you can see I've included this big long formula all about net fluid flow, talking about capillary permeability to fluid and capillary permeability to protein. I haven't typically seen this particular equation be asked about, but I want you guys to see it, to be familiar with the principle and what they're going at. Typically what they're going to ask you about is these two forces, right? So hydrostatic pushes fluid out of, so if we have a bunch of fluid buildup, it causes a bunch of pressure, and this can push fluid out of the capillaries. There's two types of hydrostatic pressures. There's capillary hydrostatic pressure, so that's what's pushing things from inside the capillary outside, and then there's interstitial hydrostatic pressure. That's what's pushing things from the interstitial space, so that's out here, into the capillary. On the other side, we have oncotic or osmotic pressures, and these pull things, okay? So this has to do with the principle of osmosis that we'll talk about in a minute. When we have more solute somewhere, it's going to pull fluid in. So if there's a bunch of solute in here, that's going to create a strong pulling force inside. And vice versa, if we have a bunch of solute out here, that's going to pull free water, it's going to pull fluid outside of the cell. So between these two forces, our hydrostatic and our osmotic or our oncotic pressure, it's going to create a net value. Where is the fluid going? This can occur in several different pathologies, right? So first one is heart failure, right? If we have heart failure, we're going to increase fluid in the capillaries, right? A classic finding of people with heart failure is lower extremity edema, right? Physical exam, you palpate it, 2+ pitting edema, classic heart failure sign. If we increase capillary hydrostatic pressure, right, that's going to cause, so let's say it's this area right here, that is going to cause fluid to leak out of the capillaries, and that's why they get this swelling, okay? Next, we're going to look at lymphedema. So lymphedema is an increase in oncotic pressure, okay? Or oncotic pressure increases. Why does it increase? Well, because we have more of a buildup of things that are going to pull it. And finally, things such as malnutrition, liver failure, and nephrotic syndrome are all going to decrease plasma oncotic pressure. Why does that make sense? The plasma oncotic pressure is directly related to the amount of proteins, so let's have green be our proteins, inside the vascular system, right? More proteins would pull fluid. But if we are malnourished, if we have liver failure, if we have nephrotic syndrome, we'll talk about that in pathology, we decrease the amount of proteins in our vascular system. So now we have fewer amounts of proteins, and thus we have a smaller pulling force, smaller oncotic force, pulling things inside of the cell. Talking about fluid shifts, so again, we mentioned this concept of osmosis. Osmosis is that water moves from low to high solute concentration. So you guys have probably seen this before, but let's say we have something kind of like this, right? A little membrane. We have, lots of solutes over here and a couple solutes over here. Where's our water going to go? Well, osmosis says that water goes from low to high. So it's going to pull this way, right? This is the whole idea of osmotic forces. And this is kind of the principle behind our oncotic pressures, our pulling forces, as we talked about on the last slide. Some examples of things that can cause fluid shifts are either, physiologic, pathologic changes or things that we can do to the patient to change their fluid dynamics. So one thing that can happen to patients, in the case of a trauma, for instance, is a hemorrhage. So a hemorrhage is going to decrease extracellular fluid overall because we're losing blood, but it doesn't change intracellular fluid. Why is that, right? So if you have 3 pieces of solute inside the cell and 3 pieces outside the cell, that's not going to cause any change, right, in terms of fluid shifting because the concentration of the solutes did not change. Even though the total amount of extracellular fluid decreased with the loss of blood, the concentration stayed the same. Thus, there's no change in intracellular fluid. Contrast this with saline infusion, right? So here we're going to increase extracellular fluid, right? We give somebody more fluid there, so that makes sense. However, again, typically the concentration of saline that we give people is pretty on par with the physiologic concentration of our body as well. So again, no change in intracellular fluid because there's no change in the concentration of solutes in the fluid we're giving them. Finally, mannitol is something different. Mannitol is a fluid that we can give people that can increase extracellular volume, but it does cause a decrease in intracellular fluid volume, and that's because if this is our cell and we have 3 solutes, for example, inside, and we give mannitol, which we know has a bunch of solutes in it, now we've created a scenario where there's, let's say, 6 pieces of solute outside of the cell, and as we said with the principle of osmosis, this is going to cause a pull of that fluid from inside the cell to outside of the cell, and thus a decrease in intracellular fluid. Finally, for this lecture, I want to talk about glomerular filtration, just the basic components of it, and then we'll talk more about kind of the physiology and the mathematics that we need to know in the next lecture. So it's 3 components. You have the fenestrated capillary endothelium, you have type 4 collagen, and you have epithelial podocytes. These are important when we start talking about pathologies. So like basement membrane, the type 4 collagen is often affected in a pathology called Alport syndrome. And then the epithelial podocytes is often affected in a pathology called minimal change disease. We'll talk more about those in our videos on nephritic and nephrotic syndromes. Finally, there's 2 parts to the barriers in the glomerular filtration. There's a size barrier and a charge barrier. This is important because one of the classic negatively charged molecules that we have in our body is something called albumin. Albumin is a large negatively charged molecule, and thus, for the most part, we shouldn't see this being passed through the glomerulus. It should not be filtered into our urine. If this does occur, then we're dealing with pathologies, again, that we'll talk about, like nephritic and nephrotic syndromes. All right, that's all I have for this one. I'll see you guys in the next one to talk about filtration physiology.